So all the logistics, it was possible because you had an experience working as a call center. So by using a call center, you could engage and you can mobilize all the resources, the government resources. And in the same time, because COVID-19 is something that we never experienced, so it was our first time, so you had to invent like VI, for example, vulnerable index. You had to invent some sort of special triage management to categorize the patients, categorize the services. It was on the fly because you didn't have any experience before, right? So we can see the importance of IT, the importance of the technology. I was just wondering if the same COVID-19 happened 30 years ago, what would happen? Without any mobile phone, they cannot communicate. Like you mentioned, like 10,000 doctors, mobile doctors, they got enrolled because they wanted to help. Yes. We found that stories are really, really very encouraging. So, so this is the story in for you, right?
Yeah.
To use your digital experience, how to tackle COVID. So it was not some sort of, you're not a medical doctor, but you had to learn everything to establish a system, to develop a system to tackle COVID-19 in 2019 or 2020. All right, the text is ready. So the floor is yours, Sharat.
So today I'm here to share, to present how we utilized, how we harnessed, how we leveraged the power of ICT to combat COVID-19 and save millions of lives in Bangladesh during the pandemic, a time when the entire nation was engulfed in fear and panic. You know, COVID-19 pandemic emerged at the beginning of March 2020. And during that time, during that lockdown situation, we couldn't meet, we couldn't greet, even we couldn't treat patient physically as the entire healthcare system was collapsed. Almost all hospitals and clinics were shut down. People were confined to their homes. They cannot move outside. They were completely helpless. They were traumatized. They were terrified. And during that time of crisis, during the time of challenges, information communication technology, that is ICT, emerged as a beacon of trust, as a source of hope for the people of Bangladesh. And it was Synesis IT. It was Synesis IT that transformed that hope into reality. Synesis IT is one of the leading ICT solution providers in Bangladesh, closely collaborated with the government to build a telehealth center to fight against COVID and saved millions of lives. I'll tell about Synesis IT a bit at the end of my presentation. So now the question is, how did Synesis IT make it happen? How did Synesis IT lead the entire journey, leveraging the power of ICT? For those of us working in ICT sector, the meaning of COVID was a bit different. It might sound funny or it might sound weird, but it is true. We know COVID stands for coronavirus disease. But for us, the elaboration of COVID was connected online via internet and devices. Inspired by this principle and driven by this motto and vision, Synesis IT partnered with the government and set up CTC. CTC means COVID-19 Telehealth Center. COVID-19 Telehealth Center is an innovative mobile health and call center based platform under the banner of Shastha Batan. I'll tell about Shastha Batan later. And Shastha Batan basically is a national telehealth center of Bangladesh government under the Ministry of Health and Family Welfare. And Synesis has been running this platform since 2015. And CTC was established in March 2020 when actually COVID emerged in our country. And CTC, the concept of CTC was designed by Synesis IT, and the goal of CTC were to minimize the spread of the virus, to alleviate the pressure on traditional health facilities, and of course to provide psychological mental support to the citizen, and of course to deliver both medical and non-medical assistance. I will tell more about it later. And over the time, during pandemic, both CTC and Shastro Batayon together served more than 20 million people in Bangladesh. Today I am here to share you the pulse founding story of CTC, our passion, our devotion, our dedication, and our empathy in serving the nation during COVID pandemic. And of course, I will share the challenge we have faced, the innovation we embraced, and the impact we have made during COVID. And I do believe, I sincerely believe, this pulse founding story will actually resonate your heart, and it will spark your thought, of course. As I told you before, CTC was established under the banner of Shastro Batayon. So to understand CTC, I first need to know about the background story of Shastro Batayon. Shastro Batayon is a Bengali composite word. It comprises two words, Shastro and Batayon. Shastro means health, and Batayon means window. So together it is health window. So the concept of Shastro Batayon or health window was developed by Synesis IT. As I told you before, we have been working since 2015 with this journey. It is a 24/7 medical call center, and the entire operation was conducted by both doctors and HIO. HIO, basically, they are health information officers. I will talk about it in my latest slide. And it has a hotline number 16263, allowing people to connect with doctors and to receive medical consultation over the phone from any phone, from anywhere. It could be mobile phone or it could be land phone. And it is totally toll-free. The service is totally free and accessible to all citizens of Bangladesh. And from the very beginning, since 2015, Shastro Batayon served more than 23 million people across the country. Now, Shastro Batayon actually offers a wide range of services. Clinical services are rendered by registered physicians, licensed doctor having MBBS degree, and that non-clinical part, these are mostly health information dissemination service, which are handled by HIO, Health Specially Trained Health Information Officer. And if you have a look, the clinical services which comprise general medical counseling service, treatment, e-prescription, I will talk about it later, and also specialized doctor service, expert doctor advices, triaging and referral service with different level hospitals, and also vaccination, immunization, also diet and nutrition. And the later part, which I told you that we are also providing health information service by HIO, and which includes health informatics, and there are some other areas we will cover. If I talk about the operation model of Shastro Batayon, as I said, it's a call center base, it's a telehealth center. Inside the call center, both doctors and HIO are working together. Say, for example, if someone from anywhere of the country dials 16263, the IVR system will be greeted to the citizen. It says, "Welcome to Shastro Batayon. If you want to talk to a doctor, please press 1. If you want to need information, please press 2. If you want to have ambulance service, press 3," and blah blah. So once the citizen press 1, the call is connected with the doctor, and the doctor is giving consultation over the phone for a long period. And during this conversation, the doctor actually enters patient information. It could be biography, it could be clinical history. And at the same time, if someone calls for health information, the call has been received by the HIO, Health Information Officer, and they provide all sorts of information. And the entire system is automated by a rover system, and we have a CRM system which actually records all the conversation during the call. And it has two kinds of large database. One is information database, and another one is clinical database. Clinical database includes more than 200,000 drugs information. Doctors' information is around more than 20,000 doctors' contact information is available in our database. Ambulance, hospital, clinics, and many more. So, and at the end of the presentation, if it is required, automatically e-prescription has been generated and which has been sent to the patient through SMS. As I said, it has a robust CRM system. This CRM system includes different kind of database, and this system actually store patient demographic information, clinical history, major complaints, and at the same time vital signs and symptoms, and of course prescribed medical e-prescription. And it has online dashboard. We can monitor the entire person sitting outside. And as I said, it has a robust database for dark disease, ambulance, hospital, clinic, and other information. And it also comprises a big, robust MIS reporting engine, which helps the policymakers of Bangladesh government. As I said, it's a kind of electronic prescription. Actually, during conversation, this prescription has been sent to the patient through SMS, and it will look like that. And if you have a look like traditional prescription, it also includes drugs, doses, and the frequency. And at the same time, if you have a look at the bottom of the prescription, you'll find the registered doctor name along with his license number. And we only provide OTC drugs in our e-prescription, since we are actually not physically investigating the patient. So we always provide OTC drugs in our electronic prescription. And one important thing, Swasthya Bandhan is highly integrated with all government and other private services like 999. 999 is an emergency hotline. Say it's like 911 in US, or in Japan, I know 110 and 119. This kind of service we are also 999 is providing, and Swasthya Bandhan has an integration with 999, and 333 is a national helpline for all government services. It is also integrated with 333, and as I said, DGHS, this is the health department of Bangladesh government. It has integration with the health department. And we have another call center, we have another medical service, which are mostly focused in psychological domain, mental counseling. So it is integration with the Mindhealth. The brand name is Mindhealth. And as I said, mostly junior doctors are receiving call. Based on the comorbidity, we can actually route the call to the expert doctors. We are calling specialized support. And it has integration with the 109, which is dedicated for maternal and child health. And as I said, it has a lot of reporting facilities. Since we have started our journey, it was back in 2015. From 2015 to as of date, we have served 23 million people. And if you have a look at the call distribution, more than 70% people, they actually call us for medical or medical counseling service, 30% for health information, and 6% for ambulance. And it has a platform. If you have any complaint regarding any health facilities, you can register the complaint to our call center. So we also received 4% information, complaint-related information in our call center. If you have a look, this is the gender distribution of over the last 7-8 years journey. 43% of calls actually came from the female, and 59.7% are from the male. And if you have a look, the age distribution of the call, you will find mostly young and middle-aged people. They are basically calling us. And this is the type of actually disease people actually called before us. And now I will like to tell you, our main goal is to share our experience in COVID time. So as you know, as I said, 90% area of Bangladesh are under lockdown, and it actually, all the people, they are confined to their home and disrupting daily life, at the same time medical treatment and other things. And more than 95% transport, except ambulance and emergency vehicle, they are halted. And more than 40,000 community clinics, they are also shut down, and also more than 5,000 hospital, government hospital, they are inactive. And at the same time, more than 90,000 health workers were working across the country, and more than 7,000 nurses, 22,000 doctors, they are actually left idle at home. And the main problem for the NCD patient, actually those who have comorbidity like diabetic patient, hypertension patient, those who have kidney and other serious issues, they are actually face a lot of problem in accessing regular checkup. And one big challenge actually they faced because more than 70% of pharmacies, they are actually inactive during that time. So in this critical time, as I said, DG Health is the health department of Bangladesh government. From the very beginning, it was horrible situation, but at the beginning, they actually took three major initiatives from DG Health. The one is, as you know, all the hospitals are shut down. The time the large hospital, they are converted into quarantine centers to treat COVID positive patients. And that time, rapidly expansion of testing centers for RT-PCR labs was established across the country, and it was rapidly extended. And this is the last thing is very important for us for CTC service. The government actually they established a control room to monitor, to manage and coordinate COVID-related outbreak activities. So they actually formed a separate unit which is called control room. Now, this is very crucial for us. Control room, actually it was central hub for monitoring, coordinating and managing the nation's response to the outbreak. So it was responsible for real-time data monitoring and reporting to manage treatment protocol, to manage patients' database. At the same time, it was responsible for coordination of health services with all health facilities, to contract tracing and quarantine management, and also distribution of logistic and other resources across the country. And the most important thing is, all the PCR lab, which actually was developed, was established across the country, they were responsible to send all patients' contact number and with name to control room, which includes patient name, phone number, and area. And this is the starting point of our journey. I will share a little bit more. So how actually started? As I said, actually each and every day more than 4,000 or 5,000 people are getting infected by COVID. And as you know, CTC was established to treat each and every COVID positive patient across the country. And the major challenge is to collect the information. As I said, control room used to collect all patient contact information, only contact number, and they send back to us at the end of the day. I will give you a high-level overview. So once we get the number, we actually contact with the relevant person over the phone, and we made a 15 minutes long call by the doctors, which we are calling assessment call. So after getting the data, it helps us a lot, and we have categorized all the patients from this data into three categories: mild, moderate, and severe. I will give more about it in my next slide. And we actually treat each and every patient for a duration of 14 days. As you know, the life cycle of COVID is 14 days. That's why we actually designed the timeline 14 days, which we are calling patient service cycle. So during this service cycle, within 2 weeks, we did a lot. I will share a bit more. And during this 14 days service cycle, each and every patient received both medical and non-medical services. As you know, medical service includes the medical consultation, giving ambulance service, and non-medical support. That time all were actually under lockdown, so we provide financial aid, we provide relief, integrating with local government, local authorities. I will share more. So we used to provide two kinds of service: medical, at the same time non-medical services from the CTC. Now I will give a high-level overview how actually it works that time. As you see, the control room, every day at the end of the day, we used to collect COVID positive cases in an Excel sheet. The control of health department, they used to send us this contact information over email. We receive the contact number and we import this data in our CRM system every day. The next following day, a pool of doctors, they were dedicated to reach each and every patient, and they used to talk with them minimum 15 to 20 minutes. And during that time, they collected lots of information. I will tell more about it, like demographic information, socio-economic information, clinical information. I will share you. So, which we are calling assessment call. Assessment call actually gives a clear picture about the patient. And based on the data, as I said, we have categorized patient into 3 categories: mild, moderate, and severe. So based on the cases, we designed 3 treatment plans. Treatment plan A for mild patient, treatment B for moderate patient, and treatment C for severe patient. And during this cycle, patient service cycle, 14 days, 2 weeks, we used to do many things I will share. And this service actually was provided by 3 kinds of doctors. One is mobile doctor, one is station doctor, one is expert doctor. This is very interesting, I will share. And the next one is HIO, which I told before that they are specially trained health information officer. And it has integrated with lots of other services of government and also from private sector, like expert doctors from BSMMU, which is the top level tertiary hospital in Bangladesh. For the people who needs mother care or child care, we connected with the mother and child call center, which we are calling Ma telehealth. Ma means mother. And there are some other, for psychological support, we used to forward the call to the Mindtel. And for ambulance, for TMC means other private initiatives, they used to provide that time video-based consultation. Sometimes we route the call. If the patient is not poor, then we used to actually connect with the TMC companies. And for relief, for giving financial support, we used to connect the LGD, local government division. But as I said, assessment call is very crucial. After getting the contact number, we used to reach the patient, and the doctor actually talked to the patient for 15 minutes. That time, they collect clinical information, socio-economic information. Actually, we categorize that. It's a kind of questionnaire. There are 4 categories in the questionnaire. Clinical information actually help us whether the patient has any comorbidity, like the patient is NCD patient, they have any issues like hypertension. As you know, during that time, the NCD patient, they actually face severe difficulties. So we used to track their comorbidity, and based on that, we actually categorize patients into 3 categories that I shared before. And we also collect socio-economic information, like whether this guy is in low income or middle or high income. If the poor, then as I said, at that time the government used to send relief, even financial aid. So we need to know the socio-economic condition of the patient so that we can provide them relief or financial aid. So and also demographic information means we try to reach the people whether they're living in rural, urban or metropolitan area. And we receive lots of calls from the rural areas. So that's why we need to know their location. And biographic information means the age, gender and other things. And this question actually doctor used to ask during their assessment call, and which helps to find out an algorithm which we are calling vulnerability index, which is, in short, we can say it VI, which is very, very important, and it's a great innovation of our, for CTC. I will share about it, why actually we use this algorithm. I will not go for more technical details, just as in a simple, this is the questionnaire. As I said, during assessment call, these are the around more than 100 questions actually we used to ask the patient to get this kind of information. As I said, this is very crucial to design 14 days treatment plan, which we are calling a strong algorithm, VI, vulnerability index. Actually, assessment call helps us to find the VI. VI actually helps because, you know, every day more than 10,000, 5,000, 8,000 people are actually get infected. If we find things manually, it is very difficult. So our algorithm helps us to categorize whether based on their comorbidity, based on their socio-economic condition, we actually categorize into 3 categories. The patients who doesn't have any comorbidity, or patient who is young or strong, we fall them in mild category. The patient who has comorbidity but not so serious, not hospitalized, we actually categorize in moderate. And the next one, if the patient condition is very severe, need to hospitalize immediately, then we fall them into severe category. Patients who are mild type, they were taken by treatment plan A. Similarly, for moderate patient, we have taken them into treatment plan B, and for severe patient, we put them in treatment plan C. As I said, there are 3 doctors. I will share more about it in the next slide. So treatment plan A was handled by mobile doctors, and the treatment plan B was handled by station doctors, and treatment C is the expert doctor. Along with expert doctors, they actually used to take care. As I said, we used to provide non-medical services, which are actually going triaging support, because as you know, we also collected lots of information like socio-economic information. For example, if they need relief and monetary support, so our system automatically made them connected with the LGD, local government division. They are responsible to send relief, to give financial support over there, so we connect with them. And we also provide ambulance service. As you know, 999 is an emergency hotline. It has a strong wing which is dedicated for ambulance service. So we used to connect if they need any ambulance services, and it will automatically route it to 999. If they are poor, so then we try to connect with the local doctors. As you know, more than 20,000 doctors are sitting idle. So if they are poor, then we try to connect nearby doctors, government doctors, and that doctor used to reach them. If they have, they are financially solvent, then we connect with the private TMC company, telemedicine support company, so that they can take video call based consultation from them. So these sort of things actually we provide. Even sometimes we used to send medicine to the patient. There are some few months that time it was very crucial and very critical. So that time we also provide medication and medicine to the end mile of the people. And we also, which is very, very important, that time, you know, when someone dead, then it becomes people get so traumatized, they even don't want to touch the patient. And during that time, we also send people from the government for burial service. There are a lot of examples, a lot of stories. So I will not go for detail. As I said, we have categorized 3 treatment plan 1, B, and C, based on the VI, the strong algorithm that actually we use. And if you have a look, the patient who are mild, who doesn't have any comorbidity, they are categorized into treatment plan A. Treatment plan A, under this group, they used to get 30 minutes, in total 30 minutes talk time during the patient service cycle that I told you for 14 days. If they are treatment B or comorbid patient, they used to get 60 minutes call and different kind of services I will share. And the last one, severe case, they used to get 90 minutes call over the time of 14 days. And treatment plan A was conducted by mobile doctors. So let me share what is mobile. You know, from the very beginning, the call was not so high. 10,000, 20,000 we could handle. We have more than 70 or 80 doctors in our office in the station. So station doctors are paid doctors who are under our payroll, who used to come physically and provide service over the phone, staying in our office. But when the number is gradually increasing, it was so crucial, it was so challenging for us to treat each and every patient. That time, we have seen that more than 20,000 doctors are sitting idle in the home. So we contacted with the Dizzy Health and discussed with them to whether we can get their contact number, and they have given us, and we tried to reach them, and we instantly made mobile apps, and where we send this mobile apps to the relevant doctors and told them, if we have time, would you like to give a volunteer service? And they get enrolled, and we got tremendous support from the doctors. More than 10,000 doctors, they get enrolled. And around every day, more than 1,000 or 2,000 doctors who are sitting at the home. Actually, once we got a lot of calls from the queue, which we could not handle, then we route this number to the doctors who are sitting at the home with our mobile apps, and they have given volunteer service. without getting any money. And they actually love to do that. And we got immense service. Those doctors are called mobile doctors. Around 70% calls are, as I said, we have categorized, 70% are from mild patient. So we used to use that mobile doctors to treat those mild patients from their home, since they are not so serious. So actually, those mobile doctors actually used to take care of this group of patients. And if you have a look, there are some other service inside this treatment plan. As I said, if somebody needs ambulance service, I will share you two stories, because we have thousands of stories. And apart from this, there are some expert doctors, the BSMMU, this is the top level hospital in our country, and it was completely shut down. That time we have formed a separate call center for the specialized doctors who are expert doctors. So the patient who has comorbidity or NCD patient, we used to connect with them to that expert doctors. Patient who has any need mother care or child care, we route it to our Ma Telehealth Center. Ma Telehealth Center means Ma means mother Telehealth Center. Patient who needs specialized support we routed them to our specialized call center, to the hospital that I told you before. And we also, as I said, if you have a look my title, we are not confined within the country. We serve even beyond the boundary. I will share. So for that, for patients from outside who are living abroad, expatriate Bangladeshi, for them we established PBC, Pravas Bandhu Call Center. I will share. Pravas means expatriate, Bandhu means friend. The call center for the expatriates, we form PBC. I will share in my next slide. And that time patient they need lots of psychological support. So we got lots of patient who needs mental support. We have another call center which has been running from the last 7 years. We route those calls to our Mindtel. Mindtel means is our kind of psychological mental health call center. So these are the major wings. And if you have a look, the numbers we have served during the time. Shastravatan itself received 18 million people only during COVID period, and other Ma Telehealth received more than 150,000 calls, and we have given specialized service with specialized doctors. The number is 187,000 calls. And for the expatriate, we have served more than 50,000 expatriate Bangladeshis who are living abroad. And for mental and psychological support, we have served more than 12,000 people during the time. If you have a look, the distribution of mild, moderate, and severe patient, we have served among all the call volume is around 285,000 calls we have assessed. Out of them, the mild patient are 72%, moderate 22%, and the severe case we have found only 4%. There are two kinds of patients who are actually staying at home and who needs actually hospitalization. So only 6.8% people actually they were hospitalized, and initially the volume was bigger, and after 50, if you have a look, majority of the deaths have occurred during 50 plus. It means the people who are actually not old, they are actually somehow they got cured. And if you have a look, majority of COVID-19 patients are recovered in age below 50 years. Those who have is above 50, the possibility of death was quite high. And every day, if you notice, because there are a lot of people are coming from Bangladesh, every day the health department used to, give a brief in the television at noon every day. So we helped a lot, because a lot of information which actually every day they declare how many COVID patients they get infected, how many patients have been died. So they actually got this information, more than 60% information they received from our service, and this is the daily report we used to provide to the health department, and it helps a lot them to in their briefing session. Our service was not confined within the boundary. We also serve the people who are living abroad. You know, more than 10 million people who are working outside, they are mostly basically worker. Especially in the Middle East, 4 million people are actually working in the Middle, and they were so helpless. They lost their job. They actually confined at their homes. It was a big challenge for them to get medical services. And that time, the High Commission of Saudi Arabia, in Saudi Arabia, 2.2 million people are living over there. They actually tried to reach us to help them, whether we could help them sitting from here. It was a big challenge for us. But somehow we have innovated a new idea, which is very interesting. I just, within in a nutshell, I will try to share. So what we did, actually, as you said, in Saudi Arabia, there are 2.2 million people are living over there, and we have found, because here we could do anything, but sitting here, giving service to the overseas patient, it was very difficult for us. And we have noticed that there are around 500 registered doctors who are practicing in Saudi Arabia, who are Bangladeshi, but they are sitting idle. So we tried to collect their information. It's like the mobile doctors that I shared before. So we tried to reach over there, and we made an application, mobile apps, and tried to send over to them to get registered, whether they can give volunteer service. And the Saudi High Commission, they have actually broadcasted the message to all experts, because they are well connected. And they used to use IMO, because it was very difficult to reach from here, but just calling from the direct line is costly, but IMO is free. And within 7 days, we have integrated our solution with IMO. And people are calling from Saudi Arabia, and our HIU received the call and doctors received the call. Based on their necessity, actually we make an online appointment with the Saudi physicians. And based on their roster, they used to reach those patients over the phone. So it helped a lot for the people who were living abroad at the time. So I will not go for the details how it actually to work. Now I will tell you two stories. This is very interesting. At the peak time of COVID, we received a call, which actually it will remain in our heart forever. On the other side, a pregnant woman. She was COVID positive. She called to our call center, and she was literally crying. She was broken down, and she was begging over the phone. On the other side, one compassionate lady doctor received the call. The pregnant lady said, "Please save my baby. They will kill my baby." And of course, our doctor replied, "You are COVID positive. It's okay, but what's wrong about your kid? What's wrong about your baby?" Then she's crying again, and she explained. Family members, they actually threatened her. They actually feared the baby might be born with disabilities, with autism. That's why they're pressuring her to abort the child. Even her husband threatened her to abort the child. Otherwise, he might divorce her. And that time, our doctor knew it's not a matter of medical treatment. It's a matter of life. It's a matter of love. It's a matter of caring. And instantly, since we have a psychological consultant, instantly the lady doctor collected all the contact number of her husband, her mother-in-law, father-in-law, sister-in-law, and next 2 weeks, following 2 weeks, our psychological expert counseled them. And once her husband be convinced, then we close the case. But 4 months later, just 4 months later, we received the call from the same woman. That time, there is no tears, only joy and joy. She was so happy. She was smiling. And she said, "I am blessed with a beautiful, healthy, cute baby girl." And the next one, actually we have thousands of stories. One day, we received a call from a rural area. A woman, she was crying, and she was telling, she used to live with her old man, father was old, and she was calling to, "Please save my father." And the duty doctors was able to know that he was having a heart attack. And instantly, she called a nearby medical hospital, and we got connected with them to the nearby medical hospital, and that ambulance rushed over there and picked the old man to the hospital. And within few days, we received another call just to give thank you. She called again. If you don't give support, if you don't send the ambulance right time, otherwise my dad could have died. Not only that, we came to know, as I said, this girl is very poor. They were actually, they don't have income. They are sitting idle. We also gave them financial aid. Again, she called to us and gave thank you. So these are a lot of cases, stories, and these are not the stories of actually, medical treatment. These are stories of life. These are stories of touching people. These are stories to winning their hearts. And we have actually received lots of international and national award from the United Nations, from EPICTA, from WITSA, and also from private sectors. But the message is, this is not our real achievement. The crest, the trophy we have received, this is not our achievement. Our achievement is the appreciation, the honor we receive from the mass people. That is our real achievement. That is our real recognition. And the last thing is, we didn't stop our, service. As you know, we all are aware, in the last anti-discrimination movement, more than 10,000 people got injured. From the last 3, 4, 5 weeks, from the last 1 month, we are giving them service over the phone. We are trying to connect with the relevant departments so that they can send money over there. So we are helping them. Not only that, just few weeks back, as you know, that more than 11 districts have been inundated by flood. And during the flood, we also tried to connect them. We also tried to collect relief and other things and trying to send over there. So the journey is continuing. Thank you very much. If you have any questions, please feel free to ask me.
Yeah, definitely. I think there are a lot of questions.